Hello and welcome to my YouTube channel. Today we'll be discussing one very important topic, and that is a GI endoscopy. Basically, we would be concentrating on indications in the clinical practice of upper GI endoscopy as well as colonoscopy. Now, a lot of doubt exists in the clinician's mind as well as in the residents when to do or when to order endoscopy and what are the important clear-cut indications. I hope at the end of this video presentation all of you, whoever is seeing this video and listening to it, would have a clear indication of when to order for a upper GI endoscopy or a colonoscopy in a particular patient. So without wasting further time, let's get started and try to go deeper into the different indications of OGDS as well as colonoscopy. Now, we would first concentrate on upper GI endoscopy or esophagogastroduodenoscopy and its indications in epigastric pain. Now, this is one of the very common symptom. Patient coming to the OPD or to the clinic with a complaint of an epigastric pain, and sometimes a doubt exists when to order for endoscopy OGDS in such a patient. What are the clear-cut indications? So let's get into the detail of the indications when you would order endoscopy, because it being an invasive procedure, you would like to have a clear-cut indication before subjecting any patient to unnecessary endoscopy. Not only it would increase the discomfort to the patient but also increase the cost of the treatment. So to understand the indications are very essential before you order such a diagnostic or even a therapeutic endoscopy. Now, upper GI endoscopy, just a brief overview before we go on to the indications. Also known as esophagogastroduodenoscopy or OGDS. It's a fiber optic or a video endoscope passed orally to visualize the esophagus, the stomach, and the duodenum up to the second part. It is the first line of investigation for most of the upper GI complaints. Route is always oral under very light sedation or a topical pharyngeal spray. Reach is from esophagus, stomach, and up to the second part of the duodenum. You can also do a biopsy. So a forceps biopsy can be used to take biopsy from different parts of the structures which are being seen. And you can also do a CLO test, a Campylobacter-like organism testing specifically for H. pylori in the same sitting. There is a risk, it's a safe procedure, but there are always a risk. A risk of perforation is absolutely negligible of less than 0.03%, and risk of bleeding is again very negligible, less than 0.1%, and sometimes aspiration risk is also there. But by and large, it's a safe procedure if done under correct precautions. Now, urgent or esophagogastroduodenoscopy indications when it is mandated urgently. These are what we call alarming features in any patient. And the most important indication of an urgent OGD is a hematemesis or a melena, either an active or a recent upper GI bleed. In a patient who comes to you with hematemesis or passage of black, tarry, foul-smelling melanous stools, OGDS should be done within 24 hours of the onset of an active or a recent UGI bleed. That is number one indication of doing an OGDS, within 24 hours of hematemesis or upper GI bleed or melena. Number two indication, progressive dysphagia from solids to liquids, suggestive of esophageal obstruction or possibly a carcinoma esophagus, should be another very common and important indication of doing an OGDS. Epigastric mass with lymphadenopathy. Any palpable epigastric mass or a supraclavicular or a Virchow's node palpation in any patient should warrant an urgent OGDS. Number four, any significant weight loss, unintentional weight loss of more than 5% body weight within a very short period of say 1 to 3 months would, which is suggestive of malignancy, would be another very important indication of doing a OGDS. Any patient with presenting with persistent vomiting of more than 4 weeks or vomiting of undigested food particles, especially in the evening, suggestive of gastric outlet obstruction, another very common indication of doing an urgent OGDS. And any patients with unexplained iron deficiency anemia, especially in male patients or in postmenopausal female patients, would also require an urgent OGDS, specifically in a patient with upper GI symptoms, to rule out any other untoward pathological condition in the upper GI tract. So these six are the absolute clear indications of doing an upper GI endoscopy in a patient as on an urgent basis, depending on the time frame, and these are what are known as alarming features. Now we have a nice criteria of OGDS in dyspepsia and epigastric pain. Now, what are the indications for OGDS in a patient who comes to you with dyspeptic features or epigastric pain? Number one, age more than 55 years with a new onset dyspepsia. Any patient who comes to you whose age is more than 55 years and who comes with a new onset dyspepsia, regardless of H. pylori status, should be subjected to upper GI endoscopy. Number two, any age, any age of the patient with an alarming features like significant weight loss or hematemesis with epigastric pain should also be going for OGDS. Number three, any dyspeptic features which is unresponsive to 4 to 8 weeks of empirical proton pump inhibitor therapy. That means you are given proton pump inhibitors empirically in a patient who comes to you with dyspeptic features for at least 8 weeks and patient still complains of dyspepsia, then that patient is an ideal candidate for undergoing OGDS. Number four, any patient who turns out to be H. pylori positive, test and treat failed, or symptoms persist, such patients should also undergo OGDS. Suspected peptic ulcer disease because of use of NSAIDs or aspirin use along with epigastric pain should also undergo OGDS. Any patient with a follow-up of a known gastric ulcer, in such cases, upper GI endoscopy should be done 6 to 8 weeks post-treatment. Any surveillance of gastric intestinal metaplastic features or dysplasia, they should undergo regular periodic OGDS, and as a pre-bariatric surgery evaluation, OGDS is a must. So these are the classical, you can say, indications of OGDS in a patient who comes to you with dyspepsia and epigastric pain. Not routinely indicated OGDS in a young patient who is less than 55 years with uncomplicated dyspepsia. With uncomplicated dyspepsia. In such a cases, you test H. pylori first. So without doing OGDS, you can test H. pylori by doing a stool antigen test, or you can also do a urea breath test and try to find out whether this patient has got H. pylori or not. And then you can give a anti-H. pylori treatment. So in such cases, you don't require OGDS as a routine. Any GERD, GERD, gastroesophageal reflux disease without any alarming features, give an empirical course of proton pump inhibitor trial first. Any functional dyspepsia where there is no basis for any pathological condition, underlying pathological condition, treat empirically first before subjecting the patient to OGDS. Any epigastric pain which you feel clearly is of musculoskeletal origin, obviously there is no indication for doing an OGDS. And immediately post recent OGDS with no new findings, you don't have to repeat again. So in such cases, you don't repeatedly do a OGDS. I hope now it is clear when to order for upper GI endoscopy in a patient who comes to you with dyspepsia or epigastric pain. H. pylori peptic ulcer disease, and what is the upper GI endoscopy or OGDS decision tree. So patient comes to you in a clinic or in the OPD with epigastric pain or a prolonged dyspepsia. If the age is more than 55 years, or if there are any alarming features in the form of hematemesis, weight loss, then in such cases we do an urgent OGDS promptly within 24 hours. And key OGD findings in such cases would be, if a gastric ulcer is seen, a mandatory biopsy should be done, 4-quadrant biopsy should be done in all gastric ulcer patients uh, to exclude any gastric carcinoma. If a duodenal ulcer is seen or a features of gastritis is seen, then do a CLO test for H. pylori to rule out, or you can also do an antral biopsy to rule out the possibility of H. pylorus infection. And repeat an OGDS at 6 to 8 weeks for gastric ulcer. Repeat an OGDS for 6 to 8 weeks for gastric ulcer. On the other hand, if the patient is less than 55 years and there are no alarming features in the form of any hematemesis or weight loss, then you first test for H. pylori by stool antigen or urea breath test. That is the protocol. And once it comes out to be positive, then give a treatment of H. pylori for at least 14 days to eradicate it. And if it comes out to be negative, then still give a trial, empirical trial of proton pump inhibitors. And if there is no response, then you give then you order for OGDS in such a patient to rule out any other pathology. So these are the, you can say, a typical way of dealing with a patient of epigastric pain or dyspepsia, the OGDS tree or decision making tree. Now, therapeutic OGDS, procedures which can be done beyond diagnosis. Number one is hemostasis. One of the very, very common indication of doing an OGDS, a therapeutic OGDS, is in a patient of hematemesis and to control hemostasis. So, if you have a bleeding vessel, you can use adrenaline injection in the bleeding vessel to control the hemorrhage. You can also apply a hemoclip application, especially in forest grade 1A and 1B ulcers. You can also do a band ligation for malarious tear, and you can also use certain coagulating techniques for different type of lesions to control the hemorrhage. You can also do therapeutic OGDS in esophageal variceal band ligation, VBL. In such a case, OGDS should be done within 12 hours for acute variceal bleed. Endoscopic variceal band ligation is preferred always over sclerotherapy. Repeat every 2 to 4 weeks till esophageal varices are eradicated. You can also do a dilatation and stenting, especially in esophageal strictures like Savory Gillard Bougie. In the cases of achalasia, we can do a pneumatic dilatation, and we can also do self-expanding metallic stents for malignant esophageal obstruction through OGDS. And of course, we can also do polypectomy and endoscopic mucosal resection. If you see a gastric polyps, you can do a smear polypectomy. If you see a dysplastic lesion specifically suggestive of Barrett's esophagus, then you can do through endoscope OGDS, endoscopic mucosal resection or endoscopic submucosal dissection. Both are very, very important procedures in a patient suggestive of dysplastic lesions like Barrett's esophagus. We can also do a PEG, percutaneous endoscopic gastrostomy tube insertion under endoscopic guidance through OGDS. So these are the common, you can say, therapeutic indications of doing a OGDS beyond diagnostic procedures. Then we can also do a surveillance OGDS. How often and when to do it? So in a Barrett's esophagus with no dysplastic features, interval of surveillance OGDS is 3 to 5 yearly. Every 3 to 5 years, you can do a surveillance OGDS. Rationally, because there is a low progression risk in such a case. But if we have a Barrett's esophagus with low grade dysplasia, if there are dysplastic features in a Barrett's esophagus, then do a surveillance OGDS every 6 to 12 months. The rationale is that you have to confirm and monitor this low grade dysplastic feature because it may turn to be a malignancy. In cases of gastric intestinal metaplasia, do a surveillance OGDS every 3 years. In cases of post-gastric ulcer treatment, as a routine, 6 to 8 weeks post-treatment, a surveillance OGDS should be done to confirm the healing and exclude any carcinoma in post-gastric ulcer. In cases of familial adenomatous polyposis, OGDS should be done every 1 to 3 years to rule out any duodenal or periampullary polyps because they are at high risk of development of carcinoma. Now, in cases of pernicious anemia or atrophic gastritis, OGDS should be done every 3 to 5 years to rule out any risk of gastric carcinoid or gastric carcinoma risk. So these are the indications of surveillance OGDS and when to do it. Now coming to colonoscopy, its indications both diagnostic, therapeutic and surveillance. Colonoscopic diagnostic indications. Number one indication for doing a diagnostic colonoscopy is a bleeding per rectum. PR bleeding not explained by anorectal cause. Number one indication. Any patient with unexplained iron deficiency anemia, you have to do colonoscopy to rule out any lower GI source evaluation. Any patient who comes with occult blood in the stool, who is diagnosed with occult bleeding in the stool by fecal immunohistochemistry or fecal occult blood test positive, then in such cases colonoscopy is warranted. Bowel habit changes. Persistent change in the bowel habits of more than 4 to 6 weeks. Now, altered bowel habits is a very general term which includes number one, increasing constipation, number two, alternating constipation and bouts of passage of loose stools, number three, any bleeding per rectum, number four, tenesmus, that means the urge to pass stools but nothing comes out. All these would be labeled as altered bowel habits. And if a patient has these symptoms of altered bowel habits for more than 4 to 6 weeks, these patients are an indication for doing a diagnostic colonoscopy to rule out a colonic carcinoma. Any patient with unexplained diarrhea, to rule out either inflammatory bowel disease or an infective colitis or a microscopic colitis. Similarly, a tenesmus or a sensation of incomplete evacuation, I've already told you, is another indication of doing a colonoscopy. Then we have abdominal or systemic complaints. Unexplained abdominal pain and weight loss is alarming feature. Weight loss is significant weight loss. Any abnormal CT. To localize the colonic lesion characterization, you would do a colonoscopy. An elevated carcinoembryonic antigen, suspicious of colorectal carcinoma, either a primary or a recurrence one, would also indicate a indication for colonoscopy diagnostic. All patients with inflammatory bowel disease, suspected Crohn's ulcerative colitis for initial diagnosis, then disease activity assessment before escalating the treatment, and exclude any cytomegalovirus colitis in severe ulcerative colitis on steroids. So diagnostic colonoscopy has an indication in inflammatory bowel diseases also. Now, therapeutic colonoscopy, what all procedures you can do? Number one is polypectomy, snare polypectomy for any pedunculated polyps, endoscopic mucosal resection for a flat or sessile polyps, endoscopic dissection, submucosal dissection for a large, more than 20 millimeter lesions. Number two, therapeutic colonoscopy indication is to secure hemostasis, especially in angiodysplastic or radiation proctitis. You can use hemoclips, adrenaline injection, even for post polypectomy bleed. You can also do a contact thermal therapy or a coagulation therapy. Stricture and stenting is another indication for therapeutic colonoscopy. Balloon dilatation of colonic anastomotic strictures. Self-expanding metallic stents for malignant colonic obstruction as a bridge to surgery or palliation. Decompression, colonic decompression of sigmoid volvulus. It is a first-line treatment if there is no hint of peritonism or peritonitis. Then you do a colonic decompression. Even treatment of decompression of Ogilvie syndrome or colonic pseudo-obstruction after a failed neostigmine therapy is also an indication for a therapeutic colonoscopy. Fecal microbiota transplant (FMT) delivery for recurrent Clostridium difficile infection superior to oral capsule, and of course India-ink tattooing of lesion site to guide laparoscopic resection is another indication for therapeutic colonoscopy. Surveillance colonoscopy for colorectal carcinoma screening and post-polyectomy. Average risk scenario: if the age is more than 45 to 50 years, the first colonoscopy should be done 10 yearly and ongoing if it is normal. If there are 1 to 2 small tubular adenomas which can be picked up, which is less than 10 mm, then 7 to 10 yearly colonoscopy. If there are more than 5 adenomas, then yearly colonoscopy is warranted. If the patient is a known case of Lynch syndrome or hereditary non-polyposis coli syndrome (HNPCC), then every 1 year to 2 years from the age of 25, these patients should undergo surveillance colonoscopy, and it can be for lifelong. Familial adenomatous polyposis, annual flexible sigmoidocolonoscopy should be done. Inflammatory bowel disease with pancolitis every 1 to 5 years. For risk stratification, a surveillance colonoscopy should be done. Colorectal carcinoma, post surgery or post curative resection, 1 year post operatively, it should be done, and then every 3 years. And if it is clear, then every 5 years. First degree relative of colorectal carcinoma, patient should undergo uh, from the age of 40 a colonoscopy every 5 years, and it should be ongoing every 5 years. So these are the indications for surveillance colonoscopy. What are the contraindications and complications of both the procedures? OGDS contraindications are any suspected perforation, which is an absolute contraindication. If the patient is hemodynamically unstable, then you have to resuscitate the patient before subjecting the patient to OGDS. Recent myocardial infarction or a severe coagulopathy, patient not cooperative or patient refusal. All these are important, you can say, contraindications of OGDS. Complications we have already seen: perforation and bleeding, very, very rare. Aspiration pneumonitis, again, very rare. Contraindications of colonoscopy is if the patient has got fulminant colitis or toxic megacolon, because the risk of perforation is very, very high in such cases. If already there is a suspected perforation, don't attempt a colonoscopy. Recent colonic anastomosis within 4 to 6 weeks, don't attempt a colonoscopy. If the patient is inadequately prepared, bowel preparation, then don't try to do a colonoscopy. You would not be able to see anything. Best is to reschedule after an adequate bowel preparation. Any severe cardiorespiratory compromise, again, one of the important contraindications of doing a colonoscopy. Complications, again, very rare. Perforation risk is always there, 1 is to 1,000. Very, very uncommon. Post polypectomy bleed can occur in about 1% of patients, and patient can also have other complications like splenic injury and all that, which is very, very rare. Now, just to recap what we have just discussed, all gastric ulcers found on OGDS must be biopsied, because gastric ulcer can harbor carcinoma beneath a benign looking mucosa. Number two, OGDS for acute upper GI bleed should be done within 24 hours of presentation. For variceal bleed, should be done within 12 hours of presentation. Forest grade 1A or 2B suggestive of active bleeding, always treat. Forest grade 2A visible vessel, treat. Forest grade 2B a clot, consider conservative management. Colonoscopy is absolutely contraindicated in fulminant colitis or toxic megacolon because of risk of perforation. Post polypectomy surveillance interval depends on number, size, and histology of polyps. Lynch syndrome surveillance starts at age 25 with 1 to 2 yearly colonoscopy, earlier than average risk screening. And colonic decompression is the first line of treatment for most of the sigmoid volvulus. especially if there is no evidence of peritonism. Surgery if peritonism is present or peritoneal inflammation is present, or there is a failed colonoscopic decompression. With that, we come to the end of this topic. I hope you would find this topic useful. If you have liked my video, please subscribe, share, and give a thumbs up. Thank you for your time.